Okay, perfect. Alrighty, so your exam, like I said, is on Thursday. This is the exam breakdown from Dr. Laverde. Um, Pretty heavy split on electrolytes and acid base, and then some on those fluids, IV fluids as well. I also do have a lot to go through tonight just because it is a heavier unit, so I'll do my best to keep it to an hour. I came up with some good, more like NCLEX application questions as well to hopefully make sure you guys are good for the exam. So we'll go ahead and get started with the fluids. When you're doing a fluid volume assessment, the points in bold are some of the most important things you need to consider when determining a patient's fluid status. Measuring INO is important. It should be, as similar as possible. So if there's a question that, no two INO are the exact same, whatever they're the closest to each other, that's going to be most indicative of like a stable fluid state, where they're putting in as much as they're putting out. Serum osmolality is the most reliable detection of fluid volume status. I would just know that fact. Urine specific gravity, daily weight, which needs to be taken at the same time every day, hemoglobin and hematocrit. We'll talk more about those in a bit. And then same with BUN and creatinine. Creatinine is actually more reliable than BUN, but we're going to talk about all of them. Fluid volume is controlled by basically your entire body. Your kidneys play a super huge role. Your heart does with cardiac output and blood pressure. Your lungs with carbon dioxide, which we'll talk about more with acid base. Your pituitary gland is responsible for the release of ADH, which acts in kidneys to conserve water or fluid. And then your adrenal glands secrete aldosterone, which causes sodium and water retention while promoting potassium loss. So the three kind of classes of IV fluids that are in the crystalloid category are isotonic, hypertonic, and hypotonic. These are things that I think you go over in skills and a few other times throughout nursing in general. I would definitely know examples of these for the exam. You should be able to list all the examples for each type of IV fluid. Isotonic works to expand volume without fluid shifts. So this is great for just run-of-the-mill dehydration. Examples are zero point 0.9 normal saline, lactated ringers, D5W, which starts off as isotonic, but as I put in parentheses, once it's metabolized, it does become hypotonic. So I would just have that noted. Hypertonic will decrease cell size. It'll, expand that plasma space by pulling water out from cells into the vascular space. And the main examples of hypertonic solutions are 3% normal saline and mannitol. And then hypotonic is primarily used for cell dehydration as well as hypernatremia. And this will do the opposite of hypertonic fluids and cause water to move into the cells. So the cells will swell. In skills, my skills professor helped us remember that by calling it hippotonic because the cells get big and round like a hippo. And I still think about that sometimes when I take these exams. And examples here would be at 0.45 normal saline and then D5W after it's metabolized and shifted out of that isotonic state. So those three were the crystalloids. The colloids then are used to expand specifically your blood plasma volume, which if you've ever done plasma donation, plasma is different than the actual blood. These are unique because they do not cross the capillary membrane. And the most frequently used is albumin. So when you see albumin, you need to think colloid, you need to think the expansion of plasma volume specifically. Here's our first question. Which of the following are examples of isotonic intravenous fluids? Perfect. Yes, lots of right answers. A and B. Um, yeah, C and D are going to be your hypertonic fluids. Okay. So the first fluid imbalance that we have is an isotonic fluid volume deficit. And this is when you lose extracellular fluid, but you're losing that fluid and its electrolytes in equal proportion. So because of this, there's none of that fluid shift from high to low, none of that. Your electrolytes and fluids are lost in equal. That's a key difference between this and the other type of fluid volume deficit that we're going to talk about. Causes, just think of things that cause your body to lose fluid. GI losses, that's vomiting and diarrhea, hemorrhaging, so internal bleeding or external, excessive sweating, and then also just decreased intake of fluid if someone's just dehydrated from lack of consumption. The diagnostics between these are super important to know. So I would definitely, identify those. I tried my best to put them in bold and different colors to help you guys. So with an isotonic fluid volume deficit, because the fluid and the electrolytes move together, you're going to see a normal sodium because the concentration of sodium is still the same, even though there's a less amount. With fluid volume deficits in general, you're going to see an increase in BUN, hemoglobin, hematocrit, and urine-specific gravity. Once you know this, you're good, but I do remember it was kind of hard to grasp that in the beginning because you think less fluid, less of everything, you have less blood, so you would have less hemoglobin. But the important thing to remember is that these values for BUN, hemoglobin, hematocrit are the concentration of that specific thing, so hemoglobin, for example, in the blood. So if the blood goes down, but that hemoglobin stays up, well, you're going to have an increased ratio there, if that makes sense. So normal sodium increased all those other things. Signs and symptoms, you're going to be looking at just your signs and symptoms of dehydration. So we're talking things like decreased urine output. Concerning is less than 30 miles, wow, 30 milliliters per hour of output. Weight loss, dry membranes, and then your tachycardia, weakened thready pulses, and orthostatic hypotension. Treatment, you can do just fluid replacement, often with that isotonic IV fluid, since we're just working on reboosting that volume versus a like electrolyte shift. And then your fluid challenge as well, which is when you specifically administer 100 to 200 milliliters over a very specific time period just to see how the kidneys handle it. And that would be via close monitoring of urine output. Now, in contrast to the isotonic fluid volume deficit, there is also a hypertonic fluid volume deficit. The thing that makes this one different is that you do not lose fluid and electrolytes in the same proportion. So with a hypertonic fluid volume deficit, you are losing more water than solute, meaning that you have increased solute in the blood. Again, the causes are pretty similar of just dehydration, those severe GI losses through nausea, vomiting, diarrhea, excessive sweating, DKA can cause hypertonic fluid volume deficit, as well as excess sodium intake. So the diagnostics for this one are almost the exact same as isotonic fluid volume deficit, except we are also going to see an increased sodium, again, because you're not losing as much solute as you are fluid. So again, those same kinds of signs and symptoms there. What makes it more unique is because of that increased sodium, you can see signs and symptoms like irritability, restlessness, and disorientation that would be more unique to a hypertonic fluid volume deficit over isotonic. And then treatment, you're going to want to give hypotonic, so think maybe 0.45 normal saline, to add fluid back without that solute to prevent your cells from, shrinking into basically nothing. I'm not going to go over this super in detail. This is just a summary slide of the last two types of fluid volume imbalances to help you guys kind of distinguish the two of them. So hopefully this slide helps you as well. Alrighty, so then we're moving on to fluid volume excess. So in this case, for a hypotonic FVE, you have increased fluid volume, like with water retention, but your solute, your sodium, for example, is not changing. It's not increasing. So there's that imbalance there, primarily caused by excess fluids and specifically excess administration of hypotonic intravenous fluids. So in opposition to that fluid volume deficit, you're going to see things like low BUN, hematocrit, hemoglobin, sodium, and urine-specific gravity. Signs and symptoms, you guys probably are familiar with these as far as fluid overload goes. You can see weight gain, distended veins, specifically that JVD in your neck, crackles in the lungs, as well as a bounding pulse. I think the most important thing that we're going to talk about is that a fluid volume excess can cause increased intracranial pressure. which, like I said, I'll talk more about it on the next slide. For early treatment, you're going to do fluid restrictions, controlled administration of hypertonic or isotonic fluids. And then if it's more progressing, you can do hypertonic IV fluids like mannitol. This is a chart. I literally screenshotted it off my blueprint, I think from last year. I have the stages of ICP, increased ICP, early progressing late, those signs and symptoms that you're going to see with each stage, and then also the treatment that you would administer. I definitely, if possible, would memorize this table or just these kind of things in general. Because I would not be surprised if you get questions, saying, what would you expect to see in progressing increased intracranial pressure, and what would you expect the provider order to be? So I would be familiar with these. Biggest like general thing is that if it's in early stages of increased ICP, you're really just treating conservatively with those fluid restrictions. But once you get progressing to late, increased ICP can be very lethal. So you're going to start treating aggressively with hypertonic IV fluids, like 3% normal saline and mannitol, as well as different diuretics. So then in a vascular fluid volume excess, this is when there's swelling from the expansion of fluid volume. The main cause that I feel like I see in clinical is going to be heart failure. The signs and symptoms are basically exactly the same as the hypotonic fluid volume excess we just talked about. And treatments, again, we're trying to eliminate fluid. So diuretics, low sodium, because water goes where sodium goes, and high protein diets as well. Third spacing. I think I saw a note either this semester or last semester that a lot of students get this wrong, just because maybe they skip over it in studying or don't have a great understanding of it. Third spacing is kind of the process of how fluid moves in response to injury. So like I said, fluid moves into tissue in response to injury, which decreases your vascular volume, that volume within your blood vessels, essentially. So in phase one, there's that loss that I just said. You lose fluid from your vascular space to your interstitial space to provide, those blood cells, those resources that your body needs to kind of start the inflammation cascade. This lasts typically 24 to 72 hours after the initial injury. And the treatment here is because you're losing vascular volume, you want to give large amounts of fluids in order to prevent shock from, decreased blood pressure. Um, However, after that 72-hour phase, that fluid is going to start to shift back into the vascular space out of that interstitial space, meaning that now we have the opposite issue. Now we're at risk for hypervolemia. So I have in bold there, the RN should know that we need to decrease IV fluids, and that the goal shifts from preventing shock to preventing fluid overload. So this is really just your understanding how the fluids move in response to injury and how that impacts what you need to do to treat them. Okay. How would you treat early signs of increased intracranial pressure? Awesome. Yep. That one is A. And I put on there the other options are all for treating progressing to late stages of increased ICP. This one's a little tricky, guys. I'm sorry. In a patient with isotonic fluid volume deficit, which lab values would you expect to see? And this is a select all that apply. I'll give you guys a minute. I'm getting some answers come through on private chat. I knew this one's going to be a little tricky because not only do you have to understand what's happening, what you would expect to see, but you also have to remember all those lab values. I'll go ahead and share the answers. It is just going to be A and B. So I had a lot of varying answers for this one. So key information here is that your sodium will be normal and your BUN, hemoglobin, hematocrit would all be high. So you just need to make sure you know those lab values. Sodium, that's a normal finding. That BUN is increased. Normal is typically 10 to 20. C, D, and F are all normal findings where you'd expect them to be elevated. And then E would only be increased in a hypertonic fluid volume deficit. So I know this one was a little trickier. Don't freak out if you got it wrong. I just would make sure you're familiar with all those ranges to be able to identify what's high and what's low. All right. Everybody's favorite part is electrolytes. Just kidding. It's my least favorite part. These are super overwhelming because there are so many of them and they all start to look the same and they all have 20 million signs and symptoms that you have to know. And it's just exhausting. Like there's no other way to put it. So I did my very best to condense everything as much as possible. I'm really focused on that key information, and we'll go from there. Per usual, if you guys have questions, just interrupt me and I'll do my best to answer them. I don't guarantee I'll be 100%, but I'll do my best. So, the three extracellular electrolytes that we talk about are sodium, chloride, and calcium. The three intracellular then are potassium, magnesium, and phosphorus. In general, with electrolyte imbalances, they can vary so greatly in people. You can see people with crazy lab values who feel fine because maybe the change happens slowly over time. If you have a faster imbalance, so it sets on like that, your patient might be more symptomatic. If it's a crazier imbalance, they're going to be more symptomatic. Whereas, if it's happened slowly or just by, one value over time, your body can kind of adapt and function at electrolyte values that would be considered out of the norm. Sodium is the first one. This is the most abundant electrolyte in the extracellular fluid, which is why we talk about it so much regarding fluid volume statuses. It is the primary determinant, again, of fluid volume balances, because where sodium goes, specifically sodium chloride, water goes. Sodium is responsible for nerve impulse transmission as well as muscle contraction and is regulated by ADH, thirst, and then your renin angiotensin aldosterone syndrome or system, sorry. Hyponatremia. So I guess before that, you need to know all of these ranges. If you don't yet, I would make a Quizlet, do some flashcards, get these ranges down pat. You need to be able to identify what's low, normal, high for each of the electrolytes. That's definitely a key part of this exam. So hyponatremia is low sodium, so less than 135. Your symptoms are going to include stupor, which is basically like extreme lethargy, um, anorexia, decreased reflexes, weakness, seizures is kind of a big one, fatigue. I did get a question, would you say to know the Bruner ones or the MCN ones? I think all throughout nursing school, I used the MCN ones, but if you use the Bruner ones, totally fine, because all of your professors know that there are slightly different values, and they're never going to give you a question that fits one but not the other. For example, I think bicarbonate, MCN is 21 to 28, and the textbook is 22 to 26. They would never say 27 and expect you to say that that's increased. They would go in the 30s. So I think I use MCN, but you can use either one. So that's hyponatremia. Severe hyponatremia is under 115, and that's when it gets really dangerous for your increased intracranial pressure. Symptoms here are extreme lethargy, confusion, twitching, hemiparesis, so weakness on one side of the body, seizures, and death. I would know all of this about increased intracranial pressure. The treatment for increased intracranial pressure and severe hyponatremia is typically 3% normal saline infused slowly, which is that hypertonic solution. Also, sometimes we see mannitol, which is a diuretic that we're going to talk about a little bit later. Hypernatremia then is excess sodium, so over 145. It can actually be from too much sodium itself or also too little water, so that sodium concentration just naturally is greater. You can see thirst, maybe even a low-grade fever, nausea, vomiting. The signs and symptoms are pretty similar to a fluid volume loss, just because, again, where sodium goes, water goes. And the treatment here is a hypotonic IV fluid. So again, 0.45 or D5W. Potassium is the primary electrolyte in the intracellular fluid or space. Um, Minor variations can be significant. And if you take anything away from potassium at all, take away its impact on cardiac function. Potassium is super, super, super important as far as arrhythmias, dysrhythmias, ECGs, heart issues across the board. Um, so hypokalemia is going to be less than 3.5, caused by things like diuretics. We'll talk about that, but furosemide can cause hypokalemia. GI losses as well as insulin use can actually lower your potassium level. Signs and symptoms here are going to be your decreased muscle activity, and then again, in a different color, arrhythmias and EKG changes. Heart, always think the heart. If it is severe, the patient can go into cardiac and or respiratory arrest. So it is pretty significant. If it's mild, you can work to increase potassium in the diet or an IV replacement if it gets more severe. Super, super important. You never, ever, ever push IV potassium. It could kill your patient, very realistically. They use IV potassium um, in lethal injections because it will just stop your heart if you push it too fast. So you never, ever, ever push, only infuse it over a lengthy period of time. Hyperkalemia, then, we're looking at potassium greater than 5. This can be caused by renal failure, so you're retaining potassium, also from potassium-sparing diuretics like spironolactone. Again, with hyper and hypokalemia, you're going to see arrhythmias, ECG changes, and you can still see those muscle weakness and cramps. So these signs and symptoms are pretty similar. In general, you're going to want to restrict potassium intake, as well as if they're on something like spironolactone, you can stop that and switch to maybe a potassium wasting diuretic. A medication that they can actually take is called polystyrene sulfate. This works by binding to free potassium and basically attaching it to your stool so that you poop out the potassium instead of just having it circulate in your bloodstream. If it is super severe, you can give IV calcium gluconate. The main adverse effects here are going to be pretty quick onset of hypotension and bradycardia. And if those occur, in dangerous levels, you would want to stop that infusion. You can also do loop diuretics, like I said, furosemide, sodium bicarbonate administration, and insulin will also decrease your free potassium. Calcium, this one has a main role in nerve impulse transmission and muscle contraction, which you'll see is kind of a pattern. A lot of them have that role. Calcium needs vitamin D to absorb. That's super important. And your calcium level is controlled by your parathyroid hormone and calcitonin, which we'll talk more about in a second. Hypocalcemia, so low calcium, is going to be less than 8.5. If you have hypothyroidism or you have your thyroid removed via thyroidectomy, that's a cause. Pancreatitis can be a cause. If you have low vitamin D, like I said, vitamin D is required to absorb calcium, so that can cause a decrease in calcium, and then as well as certain drugs and states of alkalosis. The main signs and symptoms I changed colors for again. Tetany is a huge one. So there are those different signs to check for. It's like, tapping the face and looking for muscle twitches. I don't think you need to know the details of those, but I would know those two signs, just what they are, that they check for tetany. Mental status changes, and you can also have impaired clotting and ECG changes with low calcium. Again, if it's severe, you can give calcium gluconate. Calcium gluconate, though, should not be given with 0.9 normal saline. Yeah, so that's just a note, not to give it with 0.9 normal saline. It's not that they're incompatible, but they can cause adverse effects for the body. And if it's not severe, you can just increase calcium intake via your diet. And also if you have to subsequently increase vitamin D. A lot of people will just take calcium supplements for their bones and think they're all set. But if they don't have that vitamin D absorption, they're not going to be able to do much with that calcium that they're, intaking. So hypercalcemia is going to be greater than 10.2. The biggest cause here is immobility with broken bones or spinal cord injury. So these are people who, maybe broke a femur and they've been in the bed for weeks, or, your ICU patients who have a spinal cord injury. Also hyperparathyroidism, so the opposite of what we just talked about. These can all cause excess calcium. Symptoms here are going to be thirst, polyuria, bone pain, lethargy, weakness, and arrhythmias. So not as much with calcium, but you still are going to see those arrhythmias and ECG changes, like you would with potassium imbalances. I think your professors also have some, I want to say mnemonics on their slideshows to help remember these signs and symptoms. So if those help you more, by all means, definitely use those. The treatment here is going to be calcitonin. And this one tripped me up a little bit because I thought calcitonin, that sounds like it should increase calcium just by the name. But it actually stops calcium release from the activity within your bones, and it will actually promote excretion of the calcium from your urine. So calcitonin will reduce your blood calcium level. Phosphorus works as well to reduce that calcium because it binds to it and creates like I don't know the right like chemical term for them, but they just bind together and it'll decrease that free circulating calcium. Phosphorus here, 3.0 to 4.5. Phosphorus opposes calcium always. So we're gonna start seeing a lot of similarities where, hypocalcemia is, you're going to see hyperphosphatemia and vice versa. These work in opposition with one another. Phosphorus is super important because it forms ATP, which as we know is super important for, just your entire metabolic cellular function. So again, 3.0 to 4.5. If your phosphorus is low, you have hypophosphatemia, can be caused by low phosphorus intake, excess secretion, decreased absorption. So just, you're either consuming not enough or losing too much. It can cause muscle weakness and, more importantly, impaired respiration. So that's where it gets a little bit dangerous. You can supplement this phosphorus via IV. Again, you just need to do it slowly. And that's typically only in more severe cases. With hyperphosphatemia, so your high phosphate or phosphorus levels, it can be caused by kidney disease. So we're again thinking of, things that your kidney might retain versus excrete via urine. Hypoparathyroidism, excessive laxative use. Your signs and symptoms, like I said, since they oppose calcium, they're going to mimic those of hypocalcemia. So you could see things like tetany and tachycardia. Treatment then is going to be calcium carbonate or calcium citrate, and also just working to reduce phosphorus intake in the diet. So again, definitely try your best to understand that relationship between phosphorus and calcium. And truthfully, if you know one, you can kind of figure out the other. Because again, it gets confusing to say, but like the symptoms of high phosphorus are going to be mimicking those of low calcium. And the symptoms of high calcium are mimicking those of low phosphorus. So they really do kind of work in opposition like that. Chloride, this is naturally found in all of our GI secretions, our sweat, bile, saliva. It works with sodium. That's why we see sodium chloride and NaCl together all the time. And because of that, it matches sodium. They're going to move together. Hypochloremia, low chloride or less than 97, is going to be caused by GI drainage because, again, chloride is found in our GI fluids. Low sodium intake, because, again, low sodium means low chloride, and excess fluid loss. Signs and symptoms, you could have things like irritability and tremors. Those signs and symptoms again, are going to heavily mimic those of hyponatremia. Um, with kind of understanding how these things move together, no, chloride, sodium, and water like to stay together. So where there's low chloride, there's low sodium, and there's also probably a fluid volume deficit, which is why the treatment then is to correct that underlying cause. Maybe the underlying cause is low sodium or is low, fluid volume. So something you could do would be administer IV fluids. Hyperchloremia then is going to be your high chloride. This is caused by hypernatremia or also states of acidosis. So again, your signs and symptoms are going to be the same as hypernatremia and hypervolemia, sodium fluid chloride. You're going to treat and cause that kind of, sorry, you're going to treat the cause, which sometimes can be an acid-base imbalance. You can do hypotonic IV fluids and also diuretics to, hopefully excrete some of those solutes. I think this is the last one. If I'm wrong, I'm sorry, don't kill me. This is magnesium. Magnesium functions at the neuromuscular junction and has a sedative effect on excitability. And in more simple terms, the more magnesium you have, the more sedation you have. And I think you guys are in maternal infant right now. If I'm wrong, I'm sorry. But you talk about this a decent amount with the administration of mag sulfate. But yeah, more mag, more sedation. And that's going to help you understand those signs and symptoms a little bit better. So hypomagnesemia, this is low magnesium, can be caused by GI loss, TPN, that total parental nutrition, as well as alcohol use. Um, some of the signs and symptoms are due to low magnesium inherently, but some of them are due to low potassium and calcium, which they just kind of move together. Something unique about hypomagnesemia is a bit of a psychological alteration. To treat low magnesium, you're going to try to increase the intake in diet. You can do that IV replacement via slow infusion of mag sulfate. Again, with that, more magnesium, more sedation. So you need to monitor, their respiratory rate, their deep tendon reflexes, all that type of stuff, because you don't want to overcorrect and cause excess sedation. And then oftentimes hypokalemia, so low potassium and low calcium can occur alongside low magnesium. So you kind of want to keep all of these things together while you're treating them. Hypermagnesemia, so now we're talking about high magnesium. This can be caused by kidney failure. Again, your kidney's not excreting what it needs to. Tissue injury, especially with shock, sepsis, and burns. If this hypermagnesemia is acute, you can have pretty severe CNS depression, cardiac respiratory depression, and coma. So severe acute hypermagnesemia can be very, very dangerous. Your main treatment because of that is going to be prevention. But a lot of the times, we can't stop it before it actually happens. So we can do things like fluid administration, calcium administration. This will oppose that action of the magnesium, isotonic IV fluids, and then also furosemide to kind of get those kidneys really working on excreting more effectively. Perfect. I was correct. That was the last one. This is from your professor's slides. It is a quick key function and professor notes on these different electrolytes. I'm not going to go over them each individually, but I thought this was a good slide for you guys to use to just kind of super quick bullet point those functions and other key notes for them. Again, just really understanding those key side effects, those key relationships with other electrolytes and those types of things. Okay, yay. Practice questions. Which of the following lab values is indicative of an electrolyte imbalance? So this is just strictly testing. Do you know your lab values? Awesome, guys. Yep, that one is C. The other three are all like within normal limits. Alrighty. You are working with a new nurse. Which of the following actions requires immediate intervention? Select all that apply. I'll give you guys a second for this one too. Yeah, you guys are doing awesome. This one was another one of the trickier ones. I'm seeing a lot of the right answer, so I'll go ahead. This is B and D. So A is correct. That's a low magnesium. You can expect to give something like mag sulfate. B is requiring intervention because you do not want to give calcium gluconate with zero point 0.9 normal saline. That would not be, therapeutic nursing intervention. C is an okay intervention because polystyrene sulfate is used to decrease potassium levels, and that is an elevated potassium. And D requires the most immediate intervention because you never, ever, ever push IV potassium, even if their potassium's super low. That's just not how you're going to treat it. Okay. Which electrolyte has an inverse relationship with calcium? Perfect. Yep, C, phosphorus. Which medication would you expect to see prescribed for hyperkalemia? Awesome. Yep, that is B. Spironolactone would be a major no-go um, because that will retain calcium or potassium. So that'll do nothing but hike your potassium even higher. You are a nurse working in the progressive care unit. Your patient was in an MVA and has fractured multiple bones in their right leg and has been immobile throughout their recovery in the ICU or step down. What potential electrolyte imbalance should you be looking for? I felt mean coming up with some of these. I got some feedback that like some of the questions are just like too easy. So I was trying to throw in some like a little bit trickier ones in here. Yes, you guys did good. That one is hypercalcemia. The key information in there being that multiple fractures and also repeated extended immobility that can go ahead and cause that hypercalcemia. Awesome. That is all the electrolyte content. Definitely, just in summary, those key side effects that I emphasized, potassium and the cardiac, magnesium and sedation, those types of things to know, those normal values. And also, if at any point we talked about um, medication administration, um, how to push or not push, different meds, those are all things you should know. Next is diuretics. There are only a few. Um, Thiazide diuretics, and hopefully some of this is review since we do go over diuretics in Patho 1. But thiazide diuretics are the most frequently prescribed class of diuretics, and the prototype is hydrochlorothiazide. These act on the DCT or distal convoluted tubule to block sodium reabsorption. And again, if you think this through, you know that sodium moves with water. So if we're blocking the reabsorption of sodium, we're also going to reduce our water, working on, eliminating fluids. With thiazide diuretics, it can cause potassium loss, so that's something to know. And it can also cause, if a patient's diabetic and already has issues monitoring their blood sugar, it can cause hyperglycemia. The most common diuretic I feel like I see and we talk about in nursing school is furosemide. This is the prototype loop diuretic. This works by blocking reabsorption of sodium and chloride in the loop of Henle, just another specific part of the kidney, and it reduces your sodium and chloride concentration in the blood in turn. It will increase urine output, and it's commonly used with acute kidney injury, when the kidney is already struggling to do its thing. The main adverse effect here is hypokalemia. Furosemide is a potassium wasting drug. Um, so a lot of times when you give potassium, you're going to give you give furosemide, you're going to also give it with potassium because by giving them furosemide, hey, you might help with their fluid regulation and their urine output, but you're going to tank their potassium. So you give it with a potassium supplement. I feel like I see that all the time. They're like horse pills. They're huge pills if you give them PO. Another thing with furosemide is if your patient is on digoxin, this drug duo needs to be monitored closely because furosemide can increase the risk of dig toxicity, which is something we talked a lot about in PathoPharm1. But that's something you need to be on the lookout for as well. Your potassium-sparing diuretics, there's triamterene slash amiloride. This is a potassium-sparing diuretic that acts in the DCT. It's often used in combination with your thiazide or loop diuretics to prevent potassium loss. And the main one, most common one that you probably hear is spironolactone. This will enhance your sodium secretion and will retain potassium. So again, you need to monitor their potassium intake. And a lot of times people use salt substitutes to try to control their salt intake, but salt substitutes are high in potassium. So you want to advise against those. So again, just knowing which drugs here will increase and which drugs will decrease your potassium level. Lastly, the osmotic diuretic, the main one that we talk about is going to be mannitol. This works by reducing intracranial pressure. So super, super important when we were talking about hyponatremia and how that can cause increased intracranial pressure. 3% normal saline can be given with mannitol to decrease that pressure. And then there is just kind of a cautionary use for congestive heart failure and pulmonary edema. Perfect. If a patient is on furosemide, which medication interaction do you have to closely monitor? Awesome. Yay. Digoxin. Yep. That potassium loss can increase the patient's risk for dig toxicity. Your patient is admitted in the ICU and has a sodium level of 128. They are lethargic and difficult to arouse. They have increased ICP. What medication would you expect to see prescribed? Awesome. Yep. Speaking of that, I had a patient, I think 2 weeks ago, 3 weeks ago, in the ICU who had a sodium level that was too high to read. The last one that we could read was like in the 160s, which normal is less than 145. And then they just kept skyrocketing to the point that they couldn't be read. So it was pretty crazy. But I've seen a lot of different, like, kind of interesting electrolyte imbalances, especially in the ICU setting. Which diuretic can cause hyperglycemia in diabetic patients? Awesome. Yep, that is hydrochlorothiazide. Perfect. All right. The last section for tonight, and I think I'm doing good on time, is going to be your acid-base imbalances. Um, this It's kind of one of those things where it feels like people either get it or they don't. Some people love this, some people really, really hate this. Um, I will say I struggled at first, and then it just kind of clicked. And I don't want to be a Debbie Downer, but these come back in your future classes and will be super prevalent in your nursing practice. So I'm going to do my best to explain them in a way that worked for me, and we'll go from there. But at this point, you guys, I think, did a bunch of practice questions today, and I know your professors, do a really good job with resources for these. So hopefully, we're at a good point right now as far as acid base goes. To understand, some of these acid base imbalances, just like electrolytes, you need to know normal ranges. Your normal range of your blood pH is 7.35 to 7.45. 7.35 is the more acidic side and lower, whereas 7.45 and up, you're looking at an alkalotic or alkaline state. In general, some key things you need to know. Hydrogen acts as an acid, bicarbonate acts as a base, and CO2 acts as an acid. So when I say acts as an acid, that means it's going to have a effect that lowers your pH. So hydrogen and carbon dioxide will lower that pH, 7.35, 7.30, 7.2 something. Whereas bicarbonate acts as a base, we're going to increase that pH up on the more 7.45 and upside for a more alkalotic state. Your kidneys are responsible for the regulation of bicarbonate and your lungs for CO2. And that's kind of where we get into metabolic versus respiratory imbalances. I pulled these from your professor's slide again. Same thing, just good to look over, make flashcards if you don't have them yet. Because there are some acid-base imbalances that come with, or sorry, electrolyte imbalances that come with the acid-base imbalances. For example, in an acidotic state, you might see increased potassium and calcium, whereas in an alkalotic state, so higher pH, you could see low potassium and low calcium. So I would just memorize those kind of relationships there. Just a quick check on lab values. Which of the following is abnormal? Great. Yeah, C. A is normal, B is normal, and D is normal. So yep, C is just a little bit high. Carbon dioxide being high, we should recognize that that is a risk for acidosis because carbon dioxide acts as an acid. I just said that. It's fine. It does. Hydrogen and carbon dioxide act as acids. That is true. That's on me. All right, here's the fun part. So metabolic acidosis is acid-base imbalance. And because it's an acidosis, right off the bat, we're going to see a low pH. Since we know hydrogen acts as an acid, we could expect to see that a little bit high. And also, since bicarbonate acts as a base, you would expect that to be low because in an acidic state, you wouldn't have a strong base present. Your base is going to be low. Your causes here would be loss of that bicarbonate. That can be through GI losses, GU losses, as well as renal insufficiency, but also from a gain of acid. In states of lactic acidosis or a diabetic ketoacidosis, DKA, when your body gains excess acid, maybe those hydrogen ions, you can be in a state of metabolic acidosis. The main clinical manifestations here is going to be CNS depression, as well as increased respiratory rate with Kussmaul's breathing, which is deep, rapid respirations. This is your body's attempt to compensate. This doesn't happen necessarily because of the fact that it's a symptom of metabolic acidosis, but your body says, hey, my, metabolic state is acidic, and I need to do something to fix that because my blood can't be acidic. So what it does by increasing your respiratory rate, it's going to try very hard to blow off carbon dioxide. Carbon dioxide being acidic, we want to lose because maybe if we drop that low enough, our pH might start coming back up. So that increase in respiratory rate with Kussmaul breathing is solely compensatory. But you would see it pretty frequently in a state of acidosis because, again, your body does not like that. All of these are going to be primarily diagnosed via ABGs, those arterial blood gases. You're going to want to monitor those electrolytes. And then, expect to see hyperventilation as compensation. Metabolic alkalosis then is the opposite. So we are going to see a high pH and a high bicarbonate. Those are going to match. Your high pH is showing alkalosis and your high bicarbonate is showing alkalosis. Causes here pretty much directly in opposition to those of metabolic acidosis. You're going to see a dramatic gain of bicarb. That can be through excessive antacid administration. Loss of hydrogen ions through GI losses, or hypokalemia. Your clinical manifestations then, we're looking at those electrolyte imbalances, so hypocalcemia, hypokalemia, and then also hypoventilation, which again would be a compensatory mechanism to increase carbon dioxide by ideally, increasing the amount of acid in your body to work to lower that pH back to a happy range for your body. Respiratory acidosis, we're going to see a low pH and a high carbon dioxide. And the main cause here is carbon dioxide retention, often from hypoventilation. They're not breathing enough per minute, they're not breathing effectively, causing them to retain carbon dioxide. Uh, COPD patients could be in a chronic state of respiratory acidosis because they are constantly retaining CO2. Also, patients with sleep apnea and or obesity. The acute cause, though, that you need to know is a sedative overdose. So if someone ODs on sedatives and they're having shallow, ineffective respirations, they are at immediate risk for acute respiratory acidosis. If it is acute, you can see signs and symptoms like tachycardia, tachypnea, and hypertension. So we're talking all things fast and high, high heart rate, high respiratory rate, high blood pressure. Treatment here is improving ventilation because once you can start getting them to blow off that CO2 and bring down that level, you can start seeing that pH compensate back towards a more ideal value. Respiratory alkalosis I found to be the most easy to remember just because there was less information on it, I think. Since it's an alkalosis, you're going to have a high pH, and since your carbon dioxide acts as an acid, it will be low. Your cause here is hyperventilation. So think anything that can cause you to hyperventilate. Anxiety, pain, panic attack. Um, all those types of things will cause you to breathe really fast and you're going to lose all of your carbon dioxide, creating that basic state. Clinical manifestations, think about how you would feel if you just, started breathing 40 times a minute, super shallow breaths. You might feel lightheaded. You might start feeling tingling. Maybe you feel like you're going to faint and have a change in your level of consciousness. And then also hypocalcemia, which is a little harder to feel. Which of the following is a cause of acute respiratory acidosis? Yep, that's D. A, B, and C are causes of respiratory acidosis, but when we're asking specifically for an acute cause, that'll be a sedative overdose. With which diagnosis would you expect to see Kussmaul breathing? I'm tricking you guys. So this one's actually A. I got a lot of C's in the public chat and a bunch of private ones as well. Um, and I get why you would say that, but something to remember is Kussmaul breathing is deep and rapid respirations. And if someone had respiratory acidosis, which is what a lot of you put, they would have shallow, ineffective breathing, resulting in the retention of CO2. So Kussmaul breathing specifically is a compensatory mechanism for a state of metabolic acidosis. Here's some normal ABG values. I did put that same note on there about the PDF of documents I made. I had a couple students over break email me that they were struggling with ABG interpretation. Um, Something, kind of a step-by-step process before I do some more practice questions. My very first step is looking at the pH. I don't look at anything else. I look at the pH. Is that pH high, low, or normal? Say in this verbal example, it's low. All right, it's low. I'm looking at an acidotic state. Now I'm going to look at the PCO2, or the carbon dioxide, and the bicarbonate. Since I determined I'm in acidosis, which one of those matches that finding? If my carbon dioxide's super high, you can say, great, that matches. Whereas if my bicarb's high, that doesn't make sense because bicarb is a base and I just decided that I'm in an acidotic state. So just go through, determine what matches, and that'll be your diagnosis. So I have a few practice for interpretations here. Here's your ABG results. What is the likely diagnosis? Couple different answers, but yep, That is metabolic acidosis. Again, you look at that pH, you say, great, that's low. My carbon dioxide, that's normal. So does my bicarb explain the finding? Yes. A bicarb being low indicates acidic, so those now match. So when your bicarb matches your pH, that's metabolic, and then you determined it was acidosis. If your carbon dioxide matches your pH, it's a respiratory imbalance. ABGs are here. What is the likely diagnosis? You guys are quick. That one is C. Um, and I am happy you guys all got that because I not tried, but I did trick you a little bit um, because all three values were abnormal. But because the carbon dioxide is the value that matches the finding, you can still identify that it's primarily respiratory acidosis, even though the bicarb is abnormal. You can say, hey, maybe that bicarb is going up to compensate for that acidic state. Again, here's that another tip sheet. I said this, I think, a few times, just really understanding which value matches the pH, and that'll determine if it's metabolic or respiratory. And I think that's all I have for you guys. I am really impressed. We did that in an hour. So if you missed it, please go ahead and scan the QR code. Put your email in the chat for all these resources emailed to you tonight. And then I'll stay on here for another 15 minutes or so. If anyone wants to chat or has specific questions, I'd be more than happy to go over those with you. So let me stop recording.